available. I think you talked about this at the very beginning, maybe less travel or movement for a patient. I'm not exactly sure how that would work, but those would be things at top of mind.
Yes, but for that, for example, I used smartphone applications where patients can have some kind of feedback about outcome of research and have some kind of customizable way to communicate with the site back and forth and get some medically related information about the disease, etc. And they can monitor their performance, kind of see when it started and how they physiological or other parameters were changed over time. So this is what I think it would be important for retention.
Okay. When the patients are communicating the status and monitoring on the cell phone, are they doing that with the sponsor or with the physician?
Well, it could be an academic study, then it's physicians, but it's a sponsored. What I'm talking about, sponsored clinical trial, but sponsor provides information in device and communication between physician and patient. Of course, at the end of the study, all information become available for sponsored data analysis. But improving communication definitely between physician and patient to improve kind of compliance and kind of better monitoring what's going on with the study. Patient can rate performance of the drug, add safety observations, etc.
I see, for adherence. So yeah, so there definitely are real world or real time data inputs that, based on what you've just described, could certainly advance that, although I don't see that as being like the top three of these: optimized site recruitment and retention, streamlined administration, and advanced data management. Based on what you've learned so far, do those three impact suggestions at the bottom of the slide seem reasonable and achievable to you?
Yes, certainly it's quite achievable. But reduce data cost by from 10 to 50%. Is it really possible to reduce cost by 50%? It's kind of a very high number. Is it real, kind of based on real data projection?
Depends on the baseline number of the organization. But for that, you do a really good job of sort of segueing logically into the next slide. So slide 7 is, again, based on our clients' research, the costs associated with clinical trials are on average, so there's lots of variables here, 7.6 for phase 2, 7.6 million, excuse me, and roughly 11.5 for phases 3 and 4, for a total investment, up to $30 million per program. And there's different elements of the cost here. The ones I'd like you to kind of focus on are those 3 that are in red and bold. They really align to the prior slide. So let's just take phase 3, since most people are quite familiar with those. It would be about 30% of the total costs involved with site recruitment, site retention, and site monitoring. About another 20% in the administrative staff, which is often at the CRO level, and then about just under 4% for the data management. These are the categories of costs that are really being initially addressed in the digital research network. Do these numbers, and maybe not the absolute numbers because you might have had a bigger study or something, but do the relative percentages seem in the right ballpark to you of what you're spending in these controllable cost categories?
Yes, it sounds reasonable. I would agree. It's about 1/3 would be recruitment, about 20% administrative, and maybe 10% data management. This is what I had in mind as well. Although I can argue cost of phase 4 could be slightly less in terms of recruitment. It's easy because we're talking about approved therapies, and patients have you know,